Friends, welcome to the podcast series of CSI West Bengal branch, a new initiative from CSI. Today, I am pleased to have my friend, Dr. Dilip Kumar, who is the director of Cath lab in Medica, Superspecialty Hospital, Kolkata, one of the best hospital in Eastern India. So welcome, Dilip. Can you please tell me about your journey in the field of cardiology in last decade?
Yeah, thank you so much, and thanks for having me here. So, I am Dr. Dilip, Director of Cardiology at Medica Hospital, Kolkata. So, I did my graduation, post-graduation from Banaras Hindu University. I did my DM in cardiology from Calcutta. So, I've been practicing for last 18 years. So, when I was in Eindhoven doing my fellowship there, I got attracted to field of structural heart interventions way back in 2010 when the initial work of Tavr implantation was going on. So I witnessed those, I learned those, but unfortunately in India the advent of Tavr was quite late. It came in 2014 in fact, and while it came to Calcutta in 2018-19 when we started doing TAVR interventions. Regarding other structural heart interventions, besides the normal day-to-day coronary work, I was really impressed even by you doing so much of left atrial ventricular devices, being the leader in this field. And these are basically niche therapies which are, life-saving to those where very less, options are there. So we had seen patients of inoperable aortic stenosis patients and how they were left out only for medical therapy, or those who were bleeding on NOACs and there was no other option.
So what is TAVR for common people?
Yeah, so there is disease called aortic valve stenosis, and it happens in more and more elderly population. And usually the standard of care till a decade back was surgical aortic valve replacement. But there were patients who were surgically inoperable, surgically turned down patients, and there the concept of TAVR came. And in fact, the journey of Tavr is
So it's like cardiac stent, the cardiac stent. It's a kind of stent goes inside your blocked valve. In coronary, it is a stent goes inside the blocked arteries, whereas in this, the blocked
in fact, it started with the first transcatheter aortic valvuloplasty done by Dr. Alan Crebier in 1985.
Okay.
And then the kind of Dr. Hennen Anderson speculated that
in
just
France.
Like stent.
It started in France.
Just like stent, a valve can be deployed inside the human body. And in fact, he did in 1992. Dr. Anderson deployed a valve, a self-made, handmade valve, metal frame, and then a valve, surgical, a porcine valve was taken. It was sutured on a metallic frame. It was deployed in pig, 1992. Unfortunately, he did not get any company to back up and to take it forward. But Dr. Crebier went on his pursuit, and in 1999, he established a company. Himself, Dr. Martin Leon, some of the Israeli engineers, and some of the stalwarts, and they made it, the company's name was Percutaneous Valve Technologies. Finally, it was taken over by Edwards, and then what we see here from the partner trial and the core valve and evolute trials, now the Tavr has become the standard of therapy, where aortic valve stenosis patients, the preferred treatment option at this moment is
So that means you are saying that human heart has got 4 valves that regulates the flow of blood up and down, to and fro, in one directions, like from left side to the right side to the left side, aortic valve, mitral valve, tricuspid valve, and pulmonary valve. Tricuspid valve with right-sided valve is not that killing disease, but mitral and aortic valve can kill a person. So what are the symptoms of aortic stenosis in people who are having severe kind of aortic stenosis, a valve narrowing, one valve?
Yeah.
So what are the symptoms?
Yeah, so aortic valve is just at the junction of, heart, left ventricle, and the aorta, the biggest vessels of the body. And this is responsible for the circulation, entire, body circulation. So if there is a, obstruction there, the patient present with shortness of breath, fatigue, sometimes they have chest pain, angina, and many times they present with heart failure symptoms like swelling in the lower limbs, and then swelling of the abdomen. So these are the presenting symptoms.
So that means the human heart has got one entry valve where the blood enters, an exit valve, that is aortic valve. In between, you have connections between two chambers through mitral valve, left and right. Now, as you have said, many people are asymptomatic. Some people are symptomatic in the sense of lose their consciousness, they get angina or breathing difficulties. So once you come to know that man is suffering from aortic stenosis, there are two options. Either you cut open the chest. Once you are sure that he needs some kind of surgery, so there are age-old methods of cutting the chest, putting a valve, then replacing the valve with a metallic valve or a tissue valve. And there are certain issues of doing surgery in elderly people, high-risk people, that the wound you have created may not heal, may not get healed because of many reasons. Infections can die on the table. So what are the advantages of Tavr in elderly people?
So first let me clarify. For those this Savr and Tavr, we are talking about bioprosthetic valves. So when a patient has same aortic valve disease and who is less than 50 years, these are not the same valve which we deploy. These are mechanical valves and they can last long.
So non-metallic valve.
Yes, but the problem is anticoagulation.
Yes.
Now coming to this surgical aortic valve or transcatheter aortic valve with bioprosthetic valves. So surgery was the standard of care and is still being done, especially in Asia and in our country. This is the first choice because of multiple reasons. But the science tells, the other side of the story. But when you ask me what are the advantages and disadvantages of Tavr versus Savr, so advantage for transcatheter valve is the patient can go home next day. You don't need to cut open the chest. This is a small, surgical, percutaneous hole. Keyhole is created. And even if the patient has multiple comorbidities, it can be done safely because 99% of the procedures, it doesn't require, general anesthesia. It is done in conscious sedation. So risk of procedure is very less. Patient gets home very early and the kind of the surgical scar sutures are not there.
So right. So you have Indian valves in surgical field, like Sri Chitra valve, doing very well in the sense it is there in the government hospital for pretty long time, long history. And we have also Make in India, Made in India valve. So how do you see the impact of Make in India, Made in India valve, efficacy, safety, long-term outcome, or the quality of Made in India valve?
So I can't comment on Sri Chitra valve because this is surgeon's domain. But for Merrill or Indian-made, aortic valves, percutaneous valves, they are really doing wonders. And not only they are kind of reproducing the same results as compared to other balloon expandable valves in their category. And not only in India, it is well adopted all over the world, especially in European countries. This is one of the maximum used valve at this moment.
So you are saying that it is as good as, even better than some of the European products or American products. So we have now more confidence, and we in Eastern India, in our hospital, you must have experienced a lot of Make in India, Made in India because of the cost advantage. It's not only the cost, it's the quality also, as per the European standard or American standard. So we have a lot of experience with this Indian valve. Now, the durability of the valve, people have an apprehensions, or the surgeons tell their story that these valves are not a good valve. They're not going to last forever. And you have to replace this valve within few years. You have to come back to me. So what is a durability or longevity of this Tavr procedure or Tavr valve? Is it safe to go for younger generation in his lifetime? He may require 2-3 valves during his life journey. So what is your advocacy to the people about the durability, how long it will last?
Yeah. So as these all evidence were coming in forms of partner trial, evaluate core valve, and the TAVI was getting in place in guidelines, there was a constant noise from the surgical colleagues that the Tavr valve, how much is going to outlast? So how much is going to last? And the fact that these valves are crimped, These valves are thinner, 0.24 millimeter as compared to 0.4 millimeter of surgical valves, bioprosthetic valves. So the real, concern and apprehension was there. Finally, there was a randomized control trial, which was Notion trial, and initial results came at 5 years. And then at 8 years also, the TAVR, the Tavr valve, was seen to have better hemodynamics, more effective orifice area, which was left out, and better results, significant superiority over surgical aortic valve replacement in terms of mortality, stroke, and heart events, cardiovascular events.
So, what are the situations where one should not think about surgical valves? Like if you have asthma, COPDs, I'm just giving a hint. What are the other situations where people should never ever think of doing surgery?
So it depends on surgical risk. So there are some scoring system like STS score system, Euro score. So depending on their frailty, number one is which biggest risk factor for adverse surgical outcome.
Very weak patient, people
Very weak
say.
Patient frailty. Patient with severely bad lungs, those where we give a general anesthesia and the chances of coming out is very less. Patient has renal impairment, and of course some of the like heart function and how this symptoms. So we call diabetic status,
Kidney problem.
So these all risk evaluation. If tells us that the patient falls into extreme high risk category, surgical intervention should not be done, and usually they are turned down by surgeons. Same way, we have also some of the situations where Tavr is very high risk.
Example, high age. I mean, very elderly, 85 years, 90 years, extremes of age, very high risk, very high risk.
Yeah.
What about the younger generations, younger people? Up to what age you should advocate Tavr? Beyond that age, you should never advocate Tavr.
So this is a burning question, and it's debatable. In Europe, Tavr is recommended after 75 years of age. In US, it is 65 years of age. When it comes to Indian context and how should we choose, which is the ceiling of the age ceiling, after that we should be thinking of Tavr. So it depends on two factors. First is longevity of the patient, expected longevity. How much is the patient going to live after you do the procedure?
So that means you are saying that in patient's lifetime, he may need two valves, two surgical valves, or one surgical valves, one non-surgical valves, or two non-surgical valves. So what is the problem of having two non-surgical valves, two Tavrs in his lifetime?
Yeah, so we talk about Indian context. So we Indians are a little different. We have a different morphology. We have more bicuspid aortic valves. Our life expectancy is only 70 years on average when we consider the entire population as compared to 85. So if we feel that we are getting a 65 years old patient, maximum we see that patient may require two valves. If we consider 15 years of life journey, 75 years or 80 years is life expectancy, as compared to our national average of 70. So for me, for Indian patient, mostly at the most two procedures. So it can be either a Tavr followed by a Tavr, or a surgical aortic valve followed by a TAVR. So the third procedure.
Those who are having mechanical valves, those who are on acetyltraum or warfarin, absolutely they are a no-no for Tavr. They cannot.
Absolutely.
They absolutely no.
Absolutely.
So for them, if the valve malfunctions, they have to go for another surgical valve. Now you are saying that Tavr in Tavr, or patient who has got non-metallic valve in the past now comes to you, would you recommend a resurgery, redo surgery, or a Tavr?
So it depends when the patient is landing to us. So suppose we get the patient at 75 years and beyond, definitely we're going to give them an option of Tavr. But we have to see the kind of specifications, like how is the coronary placed, how much is the risk involved when we are putting Tavr, and how much is the surgical risk. But someone who is coming at 65 to 68 or less than 70 years, so we have to give options, both the options to the patient, look at these factors, the coronary involvement, future risk of coronary disease in these patients, and the patient preference. And then we decide. So more than 75 years, or maybe in Indian context, more than 70 years, we have to go for TAVR. But less than 70, we have to give options impartially.
So, for example, if he goes to a dedicated surgeon who has never seen a Tavr, never done a Tavr, never believed a Tavr, he will always give an option for another redo surgery, another valve. So how do you change the mindset of the surgeon so that this person who needs a TAVR after a failed surgical valve to convince the patient's relative that it is a better procedure, safer procedure, or as good as a redo surgery, or even better than redo surgery. For example, stroke is much less. So how do you convince these people, or your surgeon in your hospital? How do you convince them?
So surgeons are having a difficult time at this moment, and then they are trying to catch up with our results. I tell you, in conferences when surgical colleagues are there, they tell their kind of the world after the tower came, and how aggressive they are in giving the best of the results with least of invasive kind of nature of surgery, like minimal invasive surgery or something like that. And also they are very aggressive in giving tower-like results, like more adoption of aortic root enlargement, putting a bigger size valve. If you can get a 21, 23 millimeter, don't get compromised with normal quick surgery with a 19 mm valve. So they want to give bigger valve size in these patients.
Okay, somebody does not want to do neither surgery nor TAVR, and he wants a medical therapy. Is there any medical therapy available for aortic stenosis?
Yeah, well, it is just symptom driven. So there is no therapy, medical therapy, when the patient has heart failure, symptomatic heart failure patients, and heart failure guided therapy will be there.
Medical therapy.
No medical therapy
because it's a mechanical thing. What about the strokes? Many people after CABG get strokes, after valve replacement get stroke. You put a smaller valve, you do the echo, they get again restenosis. Do you think those people who has got established high cholesterol, lipid, atrial fibrillation, these are the high risk group of people, elderly people. Now, what is the role of CT scan, good CT scan in your hospital? How it helps that CT scan imaging in selecting, choosing the right size, right patients for right indications in TAVR program?
The CT is the core in evaluation of TAVI. So even now surgeons are adopting more and more use of CT scans. So CT scan give us exact size, like we have got softwares like Trimencio. We can make out the exact annular size. We see the aorta, how much large is the aorta, the exact, the sizes of different parts of the, entire aortic tree, the femorals, where the axis is, and then also the coronary anatomy, where how much height the coronary uptakes are there. So the CT scan is indispensable. So you can't do any TAVR without a CT scan, and a good quality CT scan is mandatory. So you can't have a CT scan which is non ECG gated. It has to be ECG gated. It has to be acquired at 40% of the valve opening, so that you get.
So CT scan is mandatory.
Mandatory.
Not only for surgeon, also for cardiologists, because without that you cannot think of TAVR. Now, there was a concept of surgical standby. When we started doing orangioplasty, we used to invite a surgeon to stand by your side so that you have complications, they can help in tiding over and can come as a rescue. But those days are gone. Coronary has safe stent, safe angioplasty, imaging, ultrasound, OCT in your lab, and even your juniors can do a wonderful job. Do you think the same thing has happened in TAVR?
Yeah, but still the TAVR is not approved in centers where surgical backup is not there. But with a lot of expertise, so with the knowledge of how to go in and come out safely, how to exactly know which valve to be given and what are the precautions which needs to be taken before you implant the valve inside, the TAVR procedure is becoming more and more safe. And now there is a concern and also noise about allowing these TAVR procedures in non-surgical backup centers also. So at this moment, it's a strict no as per the guidelines, because even if it is the complication rate is less, but these complications are really costly. And if you have a surgical backup, you can save the patient. And if you don't have surgical backup, you are 100%.
So they are complementary.
Yeah.
How equipped our hospitals or our facilities are with the technology, expertise, whether we can match international standards in Eastern India?
So TAVR has grown very fast over the last 3-4 years in India as well as in Eastern India. And coming to infrastructure, thanks to the setups being corporate as well as government hospitals. The infrastructure is really getting more and more up to date. And coming to the manpower, skilled manpower, we have enough trained manpower. And this is the USP of entire young India and the kind of Indian population. We have good manpower, resourceful manpower available everywhere, scattered all across India. So we can match the international standard in TAVR procedures.
So the first patient I did in AMRI hospital required a pacemaker. So let's come to pacemaker. And the pacemaker is the only Achilles heel of getting TAVR. The incidence of need for pacemaker is definitely much higher with the TAVR than SAVR or surgical valve. So why there is the need for pacemaker, and how you reduce the incidence of pacemaker, the need for pacemaker after TAVR?
So with increasing technique, like the idea that we can implant the valve higher, going in bicuspal view, cuspal overlap view, implanting it higher.
So risk is not prohibitive.
Risk is not prohibitive, and the risk, the incidence of pacemaker is also coming down.
And we are very good in pacemaker.
And also there was a concern that if you do a pacemaker, patient will have a LBV morphology forever. But now it is also mitigated with the fact that we are going to have a CSP. In most of these patients. So that apprehension is also gone. And with valves like Accurate Neo, chances of pacemakers after TAVR is becoming less than 5%. Even with our own Hydra valve also it is less. Our own.
So you are saying there are two
less.
types of TAVR. One is your balloon mounted and one is your self-expanding. So you are saying that the newer generation of valves, they are much more compliant to the patient's need and also much more safer as far as the need for pacemaker is concerned.
Yes, it's less than 5 to 8%.
Yeah, so if they develop, you can give a pacemaker. Now, there's some of the valves are bicuspid, as you have said, most of the Indians, and some of the valves are leaking. We call it is like aortic regurgitations, AR or AI, and these are prohibitive for thinking TAVR in the past. Now that things have changed, that even if you have a leaking valve, pure leaking valve, you need some calcium to hold this valve in aortic position. So people have some apprehension from their physician or treating cardiologists that it is not ready for prime time. I'm sure it is not ready for prime time. So what are the recent advances in the field of leaking valve? We have talked about stenosed valve, smaller valve, narrower valve. What is a large valve? Even large valve can malfunction. So bigger is better, but not always. The bigger valve or the bigger leaking valve is better for survival.
Yeah, so I think you really opened up a space where TAVR is coming and filling in the position probably in future. So aortic regurgitation without calcified valves, how the valve is going to be held at same place, chance of embolization, and all these were concerned. But oversizing the valve and some anchors and devices to kind of make some strategy that valve can be held by the some scallops, the anchors. Like we have a Jenna valve, there was also a J valve. Now Jenna valve, we have a trial which is Align AR trial, and the 1 year result is really positive. And what some of the kind of enthusiasts, TAVR enthusiasts, they are saying that same kind of feeling and enthusiasm which was there earlier for aortic stenosis patients, they are feeling same way for AR patients with these newer valves which can hold itself with their anchors.
So that means it's a value addition. So not only aortic stenosis, a surgical valve failure, endocarditis, infected valve, or a leaking valve, all these can be now treated by keyhole surgery like a TAVR. Newer design, a newer philosophy. Now, that many hospitals are encouraging on TAVR nowadays. The corporate hospital are investing a lot and encouraging the young generation to learn this technique in participating live cases. Your workshop in your hospital has tremendously helped for the growth of TAVR program in eastern part of India. And now, what is the most difficult barrier or the hurdle of adopting or telling your juniors to learn from you the structural heart disease?
Yeah, so learning structural heart interventions is planning, is more of planning rather than real execution.
Focused.
Yeah, and rather than real execution. So real execution is not, requiring a lot of skills, but entire evolution, 95% of Tavr is done outside the lab. So you see the patient, you choose your right patient, you go for a detailed CT analysis, then you choose your valve. First choose your patient, choose your valve, then choose your access, and then finally
So
go and execute.
before acting is rehearsal, you are saying. Rehearsal of the
so
case.
for all those who are aspiring for structural heart interventions, they have to be very, very strong and clear about how to evaluate these patients and focus more on knowing these nitty-gritties than the actual Tavr procedure, which is in fact not very difficult one. But the entire 95% job is outside the cath lab.
Right. So you are saying that with time, the smaller valve will come, the access problem will be solved, and a more durable valve. And what is next what is the future, for innovations in the field of structural heart disease? Like a mitra clip, there's another valve, which is leaking valve in your institute. It can be done in your institute. And what are the other fields of structural heart disease?
Yeah, so we are looking at therapies for all 4 valves. So we have in investigation transcatheter mitral valve replacement, and there are some real good trials which are going on. So we have at this moment clips. So clips are wonderful device, but there's a concern that some of the leaks still remains, and then these valves, once they come in the market and the results are like Tavr. So it will be a great revolution. So everything.
So you are
master
of doing left-sided valve stenosis by putting a balloon in mitral stenosis, like plenty of thousands of procedures you have done, and it's much safer and much easier. The clip is definitely much complicated in its training, but left-sided valve, both aortic and mitral valve, you have covered. Now, coming back to the pulmonary valve, in the children, they suffer from pulmonary valve stenosis, where the simple balloon can do wonder. What about your leaking or abnormal tricuspid valve, where through that pacemaker lead goes into the ventricle? Sometimes that valve becomes leaky, large heart failure, right heart failure, post-operative, post-congenital heart disease, they suffer from right heart. What is the...
This like left out tricuspid regurgitations, leaks, if they are moderate to severe, they have very bad prognosis. And many times the surgeon, they fix it. And the best option is fixing even mild to moderate tricuspid valve leaks at the time when you are doing a left side procedures. Like when replacing mitral valve, you have to fix the tricuspid leak. If it is left out, then the surgical risk is very high. And if the surgical risk is prohibitive, then you take these patients, we have very less options. And for this, tri-clips are being evaluated. The tri-illuminate results are little positive. And we also have in India, we have a kind of a trick valve, which effectively blocks the back pressure going to liver, going to other organs like kidneys, and they recover. Also indirectly it increases the forward cardiac output. So the patient's cardiac output gets better, the kidney functions get better, liver congestion gets better. So trick valve is the option, but these are all palliative, where surgical options are closed.
So that means essentially you are saying that all four valves is a domain of a cardiologist, also a domain of surgeon. I don't disagree with that. But if they come to a cardiologist like you, life will be much easier and much more comfortable. The quality of life after doing this kind of structural heart disease program or replacement or repair of the valve by newer technology can definitely makes your life much more comfortable, and you can walk in and walk out from home to hospital and hospital to home within few hours, maybe within few days. With that, we have come almost to the end of our discussions today, friends. We have a very good experience with the structural heart disease program in eastern part of India, and Dr. Dilip Kumar has highlighted many of the main features of how this Tavr valve therapy has evolved on the globe in our region. He's one of the master of doing Tavr and other forms of device therapy in needy patients, sick patients, and he has saved many, many lives by his pair of golden hands. And I'm sure you must send some of your queries to our website and podcast link. And thanks for watching. I'll be with you with more such program in the future. Thank you, Dilip,
Thank you.
for being with us. Thank you.